There are a few things you should know before we get started today. This is a public meeting. It's being recorded. All statements made today are on the record. Second, this advisory council is governed by the Federal Advisory Committee Act, or FACA for short. FACA provides rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups like this one to obtain advice or recommendations. The voting members are special government employees and are therefore subject to conflict of interest laws and regulations, as are all members who work for the federal government. These members previously provided information about their personal, professional, and financial interests. Each voting member's financial interest and outside affiliation has been carefully screened each year to ensure that they comply with federal ethics law. The liaison representatives are non-voting members of the Advisory Council and are not subject to the same FACA rules as the voting members. Additionally, the information provided at this meeting does not necessarily represent the official position of the National Vaccine Advisory Committee or the U.S. Department of Health and Human Services. Mention of products, processes, services, manufacturers, companies, or trademarks does not constitute an endorsement or recommendation by the U.S. government, HHS, or NVAC. So with that, I will start the roll call. Bob Hopkins.
Here.
Melody Butler.
Good morning and present.
Good morning. John Dunn.
Present.
Present. Jeff Dushin.
Good morning.
Good morning. Chris Arisman.
Good morning, present.
Good morning. Lynn Friedland.
Good morning, present.
Good morning. Dan Hoft. Okay, Dan Hoft, are you on? We'll come back. Molly Howell.
Hi, good morning.
Good morning. Jewel Mullen.
Present.
Good morning. Stephen Rindergana.
Present.
Rob Schechter.
Present.
Geeta Swami.
Good morning, present.
Good morning. Bob Swanson.
Present.
Good morning. Tim Cook.
Present.
Roxana Diba. Chris Regal. Claire Hannon.
Good morning, present.
Good morning. Rebecca Coyle.
Present.
Good morning. Kelly Good.
Good morning here.
Good morning. Meredith Allen. Meredith, are you on? John Douglas.
Good morning, present.
Good morning. Carrie Robinson. And Hannah Asali, are you on? Okay. Sheena Harris. Ruben Donis. Ram Kapaka.
Good morning and present.
Good morning, Ram. Mary Beth Hans. Lamone Collins.
Good morning and present.
Good morning. Jay Slater.
Present.
Good morning. Uzo
Good morning.
Chukwuma.
Good morning, present.
Good morning. Barbara Mullock. Did I miss anyone?
Sorry for the late reply. Barbara Mollick is here.
Hi, Barbara. And
Hi.
Chris Regal has also just joined us in the room. All right. So with that, I'm going to turn it over to Dr. Hopkins.
Good morning. Welcome to the second day of our September 2022 NVAC meeting. Before I get started, I also want to thank Ann and the NVAC team for their help throughout the year in the preparation for this meeting. I'd like to start with a few housekeeping items. I want to make sure everyone's aware this is a public meeting is being webcasted on the HHS website. For our virtual members, please mute yourself when not speaking. Please don't use your camera unless you're presenting, asking questions, or answering a question. For those members in the room, please raise your nameplate to the side to indicate you'd like to raise a question or flag me down before you make a question or comment. During discussion, I ask that all members and speakers identify themselves before speaking. If I don't acknowledge you by a name and giving you the floor, this helps our note taker and others to follow along. Throughout the day, there will be opportunities for committee discussion. If you'd like to ask a question or provide a comment, send a message through the chat feature if you're on remotely. As always, members of the public can provide public comment by phone at about 2:45 p.m. today, Eastern Time. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request a space for public comment during this meeting is passed. However, anyone can submit a written comment up to 3 pages in length to nvac@hhs.gov, and those will be distributed to the committee members. I'd like to give you a few highlights from yesterday's meeting. We started with a review and approval of the report from our Vaccine Confidence Subcommittee, led by Dr. John Dunn. This report was an extensive effort over the past 2 years and should be an important tool in addressing vaccine confidence research, efforts, and education going forward. Our panel on polio provided us with a better understanding of the current status of polio vaccination and prevention worldwide and current challenges with the currently available vaccines, as well as high-level information about a new live attenuated vaccine in development, which has the potential to address limitations of our current live and inactivated polio vaccines. The monkeypox panel was instructive in providing important overview for the efforts in New York that have been the epicenter for U.S. disease, as well as the CDC and supportive efforts from ASPR and the Strategic National Stockpile. Avian influenza remains an issue which poses a risk to humans, and the brief report provided us with some understanding of the U.S. response to outbreaks in birds. The presentations providing us with a landscape of universal influenza vaccine development efforts and a bit more about one promising vaccine candidate under evaluation by NIH team are important advances we need to continue to monitor, given the tremendous worldwide impact of influenza each and every year. The presentations demonstrating reduction of risk for Alzheimer's disease and Parkinson's disease in persons vaccinated to prevent influenza, pneumococcal disease, and shingles provide insights into vaccine benefits beyond infectious disease prevention. The panel discussing the sobering milestone of over 1 million U.S. deaths from COVID-19 and the even wider public impact to families was sobering. My take-home is that we need to recommit ourselves to doing everything we can as a society to minimize ongoing impacts of this pandemic here and across the world. And we concluded the day with our federal agency and liaison representative updates and public comments. Today, we'll host several panels focused on the safety of available vaccines. First, we'll have a panel on innovations in vaccine safety data. Next, we'll hear from experts about COVID-19 vaccine safety, followed by a panel about monkeypox vaccine safety. Just before lunch, we'll hear from an expert at CDC about evaluating evidence to address vaccine safety questions. After lunch, we'll resume with a panel about COVID-19 vaccine boosters and a panel about protecting rural Americans and addressing gaps in COVID-19 vaccination coverage. And the day will conclude with public comments. As a reminder, again, please hold the 2023 meeting dates on your calendars. Our next meeting will be February 2nd and 3rd, 2023, then June 15th, 16th, 23, and September 21, 22 of 23. Please refer to the NVAC website for final details on our upcoming meetings. At this time, I'd like to start with our first panel of the day, focused on innovations in vaccine safety data. Our panelists today will discuss several innovations in vaccine safety data, and our speakers include Dr. Robert Chen from the Brighton Collaboration, Dr. Yiftach Gepner from the University of Colorado at Denver, Dr. Christopher Gast from PATH, and Dr. Allison Nailway from Kaiser Permanente. And I'll now turn the podium over to Dr. Chen with our first presentation.
Thank you for inviting me. Today I will inform you about the Safety Platform for Emergency Vaccines, or SPEAK project. There are 2 phases. That first one from May of 2019 to October 2022, and then we have some proposed activities for the next years. Okay. So For those of you not familiar with Brighton, it was founded about 2000 with the goal to build trust in the safety of vaccines via rigorous science. The problem is that unlike efficacy, safety generally cannot be measured directly, and relative safety can only be inferred from relative absence of multiple adverse events following immunization that have been studied given the size of the vaccinated population. And fortunately, most serious AEFIs are rare, and they are easily missed unless some kind of standard case definition is available. So our mission has been to develop internationally accepted standards for monitoring vaccine safety throughout the vaccine life cycle. We rely mostly on volunteers from different stakeholders, and we're doing this for about 20 years. Now, the need emerged right after the acellular pertussis vaccine trials, phase 3 trials at that time. When we started to look at an outcome as simple as fever, we realized there was quite a bit of heterogeneity. There was measurements sometimes in Fahrenheit and centigrade, where the thermometer was placed, some in orally, some axillary, some rectally. And then the timing varied between 24 and 72 hours. And so we started to develop different standardized case definitions, and at this point we have done so for over 60 of them. They're usually tiered by 3 levels of confidence, reflecting kind of the differences, for example, between clinical trials and routine passive surveillance in high-income country versus low and middle-income country data. And they've been endorsed by various key stakeholders. Now, when the Coalition for Epidemic Preparedness Innovation, or CEPI, was started a few years ago, they funded several, about kind of 5 different developers for each of their target pathogens. And they realized that there was some risk in this approach in that safety signals may be missed in a single trial. And so that then became an opportunity for the SPEAK project to be formed, where we try to enhance vaccine safety assessment across the entire CEPI development program. We try to harmonize these vaccine safety monitoring during preclinical and clinical trials, and then provide a continuous improvement framework. So the SPEAK 1.0 project was divided into 5 work projects. The first one, first work project focused on creation for the first time for a meta data safety monitoring board. Most of you know that DSMB are responsible for the preclinical safety monitoring. And historically, there was actually no requirement that DSMB members have expertise in safety. The only requirement is that they are knowledgeable about the target disease that the trial is being organized on. And for vaccines, this tend to be infectious disease expertise, but safety expertise is actually rare disease expertise. And so we want to make sure that people actually with safety expertise sit on these boards. And then secondly, and then I should say that, so what we did was we have liaisons that were assigned to each of these CEPI DSMB trials. And then secondly, we want to make sure that there was a global pool of potential DSMB members with this requisite expertise, and so we've set up a training course for that. Our second work package, Part A, focused on standards and tools, where we try to identify the adverse events of special interest, AESI, for each of the target pathogen vaccines. And then wherever needed, we develop the Brighton case definitions and companion guides. So, for example, when we looked at Lassa fever, we realized that 1/3 of the people after the infection developed sensory neural hearing loss. And we will want to make sure that none of the vaccines that against Lassa fever caused sensory neural hearing loss, and yet there was no case definition for that. So we developed such a case definition. So then the Part 2 of that second work package focused on developing vaccine safety templates. We realized that in this era of very kind of high-tech vaccines, much of the literature is filled with acronyms, and many of the key stakeholders have a difficult time understanding the key information. And so these templates formulate, kind of divide into about 10 chapters, and each chapter chapter describe the question in a way that's understandable to the general public. For example, does this virus, vaccine virus, replicate in immunocompromised animals? So the answer may be complicated, but the questions are understandable, and it functions in many ways like a airline pilot's checklist for managing risk across multiple complex systems. Then the rest of the work packages are kind of more kind of management in terms of quality assurance, coordination, and then some contingency for a disease X. So our key accomplishments in the first 3 years is that we, for the first time, did have operational Meta DSMB monitoring all the different CEPI-funded trials. We had 3 DSMB training courses. The AESI list for CEPI pathogens were developed, and the one for COVID-19 was adopted widely by many stakeholders, and it predicted 11 of 14 signals for serious event that eventually were identified by the European Medicines Agency. And the 3 that we did not identify ahead of time are listed on the right. We hosted a consensus webinar on vaccine-associated enhanced disease early in March of 2020, at a time when the field had concerns that this might inhibit vaccine development, and that meeting did allay concerns in the field and allow us to move ahead. We developed novel case definitions and companion guides for multiple AESIs for COVID-19, and they're again listed on the right and the bottom. And the Pfizer colleagues did compliment us in terms of having the myocarditis case definition really help them when that emerges, safety issue to manage that issue. We developed the safety templates for each of the 5 new vaccine technology platforms, ranging from nucleic acid to protein to inactivated live viral, et cetera. And then we were able to support the different CEPI awardees in terms of various safety issues that arose. Now, looking ahead to CEPI 2.0, the aspiration is to reduce the vaccine development time for COVID that occurred in approximately 300 days to even further down to 100 days, which is obviously a very aspirational goal, especially in terms of safety data. And so for Speak 2.0 in red are kind of the proposed additional activities that we hope to embark on. So first is to develop a kind of a digital transformation of our case definitions to make them more available in a digital and more timely format. The second is to basically take advantage of the fact that the rare cases, serious cases of myocarditis and TTS, et cetera, as well as similar about 50,000 such reports to VAERS every year, is a on-tap resource to better understand pathophysiology and adversomics of why some people are unlucky to have these AEs. And if we could understand that, we could potentially prevent these injuries in the future. Work Package 6 proposes better understanding of special populations in like children, pregnant women, immunocompromised, medically at risk, so that in a hurry we could hopefully use the vaccine in these at-risk population. And Work Package 7 focuses on how we can improve active vaccine safety surveillance in low and middle income countries. So overall, we recognize that the challenge in this field is that when these AEFIs and AESI occur, they're frequently rare, they're fragmented, they're local, and they're siloed, and which makes it very hard for the field scientifically to move ahead. And we hope that we can build on our lessons from 1.0 and then use the CEPI resources as capstones to kind of bring these different activities into fruition, interlinking them into in a functional manner that then allow public confidence in these new vaccines to be built. Back when I started the Immunization Safety Office at CDC, we kind of highlighted the different domain of activities that have to be created and made functional and brought together to work in a functional system in order for vaccine safety to monitoring to work and then promote public confidence. And so it starts off with kind of hypothesis generation on the far left, be it by passive surveillance systems like VAERS, be it by rapid cycle analysis in the large link database. And then there are a couple of stages of hypothesis clarification in terms of whether clinical syndromes might exist via clinical assessment. We need kind of standardized case definitions I just described. And then on the right, the active surveillance with the vaccine safety data link type large link databases. And then on the bottom, obviously, the issues of risk perception and communication for public confidence, and then vaccine technology development to ensure that new, safer vaccines are available. And so I think all of these pieces allow us to hopefully view this issue from a more broad perspective in terms of how we can continue to improve the system. And then last, a few potential areas of synergy going forward. While we've developed case definitions, nothing is static. We need to continue to evaluate and update them. We think that there's a real opportunity to continue to collaborate on these pathogenesis studies of AESI-X across NIH, FDA, CDC, as well as countries around the world. And the goal at the end is we wish to prevent vaccine injuries whenever it's possible, not just target elimination of vaccine preventable diseases. We need to build capacity for training vaccine safety researchers because this is a challenging field where we are combining knowledge in both infectious disease as well as rare disease epi skills, and each of these tend to be siloed by themselves previously. We need to replicate the functional kind of U.S. high-income country pharmacovigilance system structure that we saw in COVID to low and middle-income countries, where some new vaccines are likely to be introduced first before high-income countries use them, and currently these countries simply lack that functional PV system. And then there's this project called the Global Vaccine Data Network that is making some efforts in that domain that you may be interested in hearing about in the future. And obviously, we're open to other suggestions. And then these are some of the folks that help us make Speak possible. So thank you for listening to me about Speak today.
Thank you very much, Dr. Chen. Our next presenter is Dr. Yiftach Gepner from the University of Colorado at Denver. Dr. Gepner, your slides are up. You have the floor.
Good morning, everyone. Thank you for inviting me to talk here today. I'm currently in sabbatical in University of Colorado, but originally I'm from Tel Aviv University, the Faculty of Medicine. And I'm going to talk today about a safety assessment of a vaccine and moving, in my opinion, forward from subjective evaluation to objective evaluation. As we all know, the key clinical trials that demonstrated the efficacy of the vaccine also was mandatory, tested the safety of the vaccine. And it was reported in those key publications that is, sorry, I'm a bit excited, as mandatory to report it, as I said, other safety assessment like headaches, fatigues, and other side effects of the vaccine. Similar to other vaccination, they found between 30 to 50% of side effects or other symptoms. And it was reported in Pfizer and Moderna and other vaccination that it has been after 5 to 20 days, by electronic questionnaire, there was some local and systemic symptoms, including at the injection site, but also headaches and fever. It was a sensitive analysis for different ages and genders, but it was mainly reported by electronic questionnaires and self-reported. And when I'm looking at the data as epidemiologist, but also as a physiologist, that looking on the reported symptoms, in the first dose, there was reported about 90% of the participants were reported those safety reported symptoms. But for the second dose, there was only 75 to 83% reported those symptoms, which means we have about 1 to 4 of the participants who didn't report the safety of the vaccine. And although the tremendous improvement in technology, where we're able to return monitoring continuously vitals, physiological vitals of human indicators or parameters, they're rarely used currently as a safety assessment of the vaccine. And they're all based on self-reported. Some of the studies did provide body temperature monitoring, but they all reported mainly. And as a physiologist, when we are measuring sport exercise, this is my main field in the study, we not rely on self-reported. We want to measure those symptoms, and those vitals or parameters can provide us much more accurate data of the safety of the vaccine. So we did publish in a study that we're trying to measure those symptoms in patients that was hospitals in Israel with COVID-19, and we did monitor them with the advanced medical grade FDA cleared monitor to look on the acute symptoms as hopefully to be able to do early detection of adverse outcomes of the vaccine or from the COVID. But in this study I will talk on, I was collaborating with 2 other scientists, Shmueli and Dan Yamin, and we were trying to evaluate the short-term effects or the short-term safety of the COVID-19 vaccine based on Pfizer using objective and continuously physiological measure. Basically, we attached to the 200 subject chest patch monitor, FDA cleared, the first FDA cleared to determine not only heart rate and blood saturation, but also other advanced vitals, including stroke volume, cardiac output, respiratory rate, systemic vascular resistance, heart rate variability, skin temperature, and other parameters that will be able to provide us more accurate and objective measurement of the vaccine. We also monitor 14 days of a self-reported questionnaire using an app that was developed for this study. So we had a total of 14 days of subjective, but also 4 days of objective evaluation of the vaccine. Most of the participants, based on the IRB that we got approved for healthy individuals, most of them were young. Some had comorbidities, but the majority of the participants were healthy. And we also provide them a personal report in order to participate in the study. What we did found is using those advanced vitals that in the first 48 hours post-vaccination, most of the vitals were increased in the next 48 hours and return to baseline. And this gave us another accurate and objective evaluation of the safety of the vaccine. Next, we looked on the local and systemic reaction reported by the participants using the mobile app that was developed for this study. And very similar to the key paper, we found between 30 to 50% of the participants reported symptoms, including headaches, fever, fatigue, and other symptoms. But what was more interesting and to our knowledge, never been reported, what is the association or disassociation between the reported and the measured symptoms. So we did a sensitive analysis that when we stratified our study population to those that had the symptoms, that reported the symptoms using the app, and those that did not report any symptoms. And we also stratified it using the daytime and the nighttime, because as obviously nobody reported symptoms while he's asleep. So we find this association between the reported and non-reported, but more interestingly, the asymptomatic subject also measure with increase in some of the vitals, including skin temperature, heart rate, but also cardiac output and systemic vascular resistance, both the daytime and the nighttime. So to conclude in this study that just published earlier this year in Communication Medicine, this study provides objective evaluation of the safety of the vaccine, another important evidence in science that showing the safety of the vaccine. Interestingly, we found that basically all 13 chest pet vitals, I didn't mention this, a BioBeat Israeli startup that developed this sensor, significantly change both in symptomatic and non-symptomatic participants. And if you're talking from a public health perspective, in order to increase the compliance to the vaccine, it gives us another proof and evaluation of the safety of the vaccine, both for people that report and not report symptoms. And we believe that this step is important as a proof of concept to move forward from subjective evaluation, but also to have objective evaluation, at least as a sub-study of any new vaccine or other new treatment. Thank you.
Thank you, Dr. Geltner. Our next presenter is Dr. Christopher Gast from PATH. Dr. Gast, your slides are up. I see your face. You have the floor.
Great, thank you. I'm sorry I can't be there with all of you today. It sounds like you heard a bit about polio yesterday. You'll hear a bit more about it here, so I'll try and go very quickly through the introductory material to get to the part related to safety for this panel. So next slide, please. I'm talking today about a novel oral poliovirus vaccine. You might ask, why do we need NOPV2? You may also know that wild type poliovirus type 2 was eradicated in 2015 with the global polio eradication strategy involving type-specific cessation of OPV usage in routine immunization. And that's due to the risk of vaccine-associated paralytic poliomyelitis, which I'll call VAP, and circulating vaccine-derived polioviruses, CVD-PV2, based on ongoing use of the vaccine. So with the eradication of type 2 declared in 2015 and 2016, there was a globally coordinated cessation of type 2, the type 2 component of the oral vaccine. Next slide, please. And this is what we saw. On the left of the figure, you see 2016 with very few cases of circulating vaccine-derived polioviruses, quickly expanding in the pre-COVID era across geography, mainly in Africa and Asia. And this was due to inadequate type 2 immunity generated prior to the switch, inadequate IPV supply available after the switch, and then the use of monovalent oral poliovirus type 2 that was used in stockpiles, actually seeding new outbreaks. And those are the green dots that you see there. So this motivated the need for NOPV2. And of course, let's do 3 more clicks. Of course, we see even more recent motivation for having NOPV2 around, with the US now confirmed as one of those countries with a circulating vaccine-derived poliovirus. So next slide, please. And so fortunately, based on decades of prior research in the mechanisms and determinants of attenuation of polioviruses, in 2011, the Bill and Melinda Gates Foundation funded a consortium of scientists to come together and identify vaccine candidates to replace the Sabin strain vaccines to be used as outbreak response vaccines that would have lower risks of vaccine-associated paralytic poliomyelitis and lower risks of becoming paralytic CVD-PV2s. And between 2011 and 2015, 2 such candidates were developed. By 2015, 2 were selected based on the criteria listed on this slide. However, you'll recall that the cessation of type 2 was planned in 2016, which did not allow time for a full clinical development program with these vaccines to be conducted. So next slide, please. So what the consortium did, along with a couple of other partners, was conduct, on the bottom row, you'll see 3 prospectively designed and conducted historical control studies intended to be ultimately used as historical controls for all of the studies on the top, which are the studies with the NOPV2 vaccine candidates, including a phase 1 in full containment, phase 2s in adults, and then target pediatric populations, and now with an ongoing phase 3 study. So next slide, please. So the endpoints collected in these studies were all of those that you would expect in a vaccine study related to safety with solicited, unsolicited adverse events, labs, vitals, that sort of thing. Immunogenicity is relatively simple with polio. We have an accepted correlate of protection, which is a neutralizing antibody response. And we also measured the frequency and duration of viral shedding in stool in these studies. So there's really nothing unique about these except for, yes, thanks, except for that first study that I mentioned being conducted in full containment, 30 participants for at least a month in full containment in a purpose-built facility in Antwerp. Following this study, and based on the evidence collected in this study, the containment advisory group provided an exemption for NOPV2 to then be used in clinical trials outside of this study. One more click, please. So the thing that I want to talk to you most about here is that you know what we're trying to do, what NOPV2 was designed to do was to be able to stop outbreaks, so be sufficiently immunogenic to stop outbreaks, but also reduce the risk of vaccine-associated paralytic poliomyelitis and reduce the risk that if the virus does become transmitted in these under-immunized areas, that it doesn't actually revert to a neurovirulent form and cause paralysis. So it is essentially a question of safety of the vaccine or of the mutated vaccine that could exist in areas of under-immunization. So next slide, please. And so there's mutations introduced into NOPV2 that enhance the fidelity of replication and limit the ability for the virus to recombine into a neurovirulent form. And there are other attenuating mutations built on top of those already in the Sabin virus. So we can monitor these through next-gen sequencing, and we can find out if those known attenuations common to the Sabin vaccine, if those attenuations are lost, and we can find out if the attenuations that are built into NOPV2 are lost, but we can't tie that to a safety risk directly. And so we will be able to quantify the loss of attenuation, but we don't know what it means. We don't know if the virus might find other paths to losing attenuation and becoming neurovirulent. So because of that risk, we felt the partners felt that we would need a phenotypic evaluation of genetic stability to be conducted instead. Next slide, please. So what we had available to us was there's this monkey neurovirulence test that has been used for a long time in polio vaccine production as an indicator of consistency. And 30 or 40 years ago, there was developed a mouse line and a corresponding test that could be used to evaluate as a replacement for the monkey neurovirulence test. And these mice are known to be susceptible in both a dose response way to the amount of vaccine administered, but also there's a very clear response to vaccine versus vaccine that has lost attenuations versus wild type poliovirus. And so you can very clearly associate the neurovirulence of the vaccine that is known from the loss of attenuations with the paralysis of the mice. And so that actually provides us a way to compare both vaccines, but also shed virus from vaccines in a way that can actually be mapped reasonably well to what you would expect to see in terms of VAP risk in humans. And so next slide, please. We decided to take the mouse assay and look at that and see if that could be used to evaluate clinical samples from our clinical trials. So virus shed from stool, we want to know, is it more or less neurovirulent than the virus shed from the existing vaccine? Remember the historical control trials that I showed you. But the problem was this assay requires 64 very special and very expensive mice. And if you imagine a clinical trial, a head-to-head clinical trial with 100 participants, you end up very quickly with something like 50,000 mice. So next slide, please. So what we needed was a higher throughput version of that assay. We needed to evaluate only the most important stool sample from each trial participant, and we needed to do it in a one-dose assay that had high power, discriminatory power to distinguish NOPV2 from the Sabin monovalent type 2 vaccine. So next slide, please. We defined the most important sample as the last sample collected from a subject, so we're giving it the most time to lose its attenuation during replication. The last sample that could be amplified in cell culture without inducing bias in the amplification process, such that it could be amplified to a level necessary for both the NGS assay as well as to be used as an inoculum for this modified transgenic mouse neurovirulence test. Next slide, please. And through some assay development, what we found is that on the x-axis here, that's the inoculum level into the spinal cord of the mouse. That an inoculum of about 4 logs provided the greatest discriminatory power between the reverted Sabin2 virus, which you'd expect to see after about a week in vaccinees, and what we expected to see preclinically from the NOPV2 vaccine. And so that was the inoculum dose that we used. Next slide, please. I'm going to jump really quickly to results because we don't have a lot of time to get very, very deep into this. But what you see on the left panel is from the phase 2 study. Those are 1 to 5-year-old children. We took their stool samples and put them in this assay, and we had very few of them in the yellow bar, the historical control study. But you can see that some of them had reverted and caused a lot of mouse paralysis. And on the right-hand side of that leftmost panel, you see very limited paralysis from the NOPV2, the stool from the NOPV2 subjects. The 2 panels on the right were the primary infant groups that we wanted to look at, and so we took stool samples from the historical control and the NOPV2 study. We actually used a 2-dose assay, so you see inocula of 4 and 5 logs there. And you see exactly the same behavior. You see large amounts of paralysis from the stool of MOPV2 vaccinees and very limited paralysis from the stool of NOPV2 vaccinees in a dose-dependent manner. And all the text on the right just shows you that the primary endpoint here for this was met with the odds of paralysis very significantly lower for the new vaccine, which we were very happy to see. Next slide, please. And you can also see the x-axis now is the day of collection of that sample that was submitted to the assay. And so you can see the speed with which the attenuation is lost for the Sabin strain vaccine. Those are the yellow dots versus the blue dots. And so as subjects are shedding transmissible amounts of virus in the first maybe 3 to 14 days, you've got a much, much more attenuated virus, much less likely to revert to a neurovirulent form. Next slide, please. And so let's go actually 5 more. I'd love to talk to you for a very long time about how those phenotypic results line up with the genetic stability results. There's actually a pretty tight correlation, and we can use the genetics, the sequencing results to predict in large part the neurovirulence results, but I'll just run through the highlights here very quickly. There was no thermostability increasing polymorphisms in domain 5, which is the main site of attenuation of poliovirus vaccines. There are unprotected sites in both vaccines. You can't over-attenuate a live virus vaccine, or it won't be a vaccine. We did see the expected reversions there, but nothing nearly nothing that increasing the risk above and beyond what you would see with the existing vaccine. And in the very worst case sample that we collected, it was still at least 2 logs more attenuated in that phenotypic assay than the standard partially reverted Sabin strain vaccine. And so the conclusion is that NOPV2 is significantly less neurovirulent than MOPV2. And this linkage has enabled, during the rollout of NOPV2, we can monitor the virus using the association between the next-gen sequencing and the neurovirulence from the clinical trial data to monitor shed virus samples that are collected through environmental surveillance and AFP surveillance in the field. Next slide, please. And that's really, it's sort of mapped here, the loss of attenuations for the yellow, the Sabin strain vaccine versus the NOPV2 vaccine. So you can refer to that reference for more detail on the evolution of the genome of NOPV2. I think one more slide, please. And so this is just a summary slide with some links if you have access to the slides for all of the clinical data that have been collected. And just noting that since 2021, early 2021, when deployment began, 450 million doses of the vaccine have been used so far, and the experience from the rollout has been consistent with our clinical trial observations, which has been very nice to see. So with that, I'll stop there.
Thank you very much, Dr. Gast. Our next presenter is Dr. Allison Nailway from Kaiser Permanente. Dr. Nailway, your slides are up. I see you. You have the floor.
Great. Thank you so much. Good morning, and I am going to describe the development and enhancement of some algorithms to identify pregnancies in the Vaccine Safety Data Link. Next slide, please. So we have had developed and validated algorithm, which we call the pregnancy episode algorithm, or the PEA, for over a decade now in the VSD. Currently, the algorithm identifies pregnancies dating from 2002 through present. And the algorithm consists of a very long list of diagnosis and procedure codes that can be used to identify pregnancy-related care, so codes for things like prenatal visits. And it can also identify pregnancy outcomes, like codes for live birth deliveries. And there's also a complicated SAS program that goes along with the algorithm and helps us identify pregnancy episodes. So the PEA looks for pregnancy episodes that have an outcome, including non-live birth outcomes, and then assigns start and end dates to those outcomes. Next slide, please. This schematic has a lot of VSD-specific jargon on it, but just to walk you through how the PEA works. First, the SAS code looks through all of our standardized VSD files. So these are files containing things like diagnosis codes and procedure codes, and it looks for pregnancy indicators. And then it sorts through those indicators through a data hierarchy to determine which of those codes best indicate a pregnancy end date and the outcome type. So it'll assign an outcome type such as a live birth or a spontaneous abortion. Then the algorithm goes through the data through a second hierarchy to estimate the pregnancy start date and gestational age. So for the original pregnancy algorithm, if there were birth certificate data or EMR, electronic medical record data available with gestational age information, and this was usually only for live births, it would assign the gestational age using those data. If those data weren't available, the algorithm simply imputes a gestational age that's specific to the outcome type that's based on published national averages. So for live birth outcomes, it assigns a gestational age of 40 weeks, for example. And then the algorithm creates a file for us that we use in the VSD that has pregnancy episodes, and we can use those to link to information about vaccination or other diagnoses that occurred during the pregnancy. Next slide, please. So currently, we have just over 2.8 million pregnancy episodes in our VSD data files. You can see the breakdown of the outcome types there. So 75% of these episodes are live births, 12% are spontaneous abortions, 10% are induced abortions, less than 1% are stillbirths, and then we have 3% which fall into another outcome category. And these include things like ectopic pregnancies and some type of outcomes that we know a pregnancy has occurred, but there's not enough data to really help us nail down what type of outcome it was. So there's some categorized in there as unknown outcomes. Next slide, please. So the PEA successfully identifies pregnancies that have an outcome, and it uses linked birth record data when available. But some of the challenges with the PEA is that it only identifies completed pregnancies, and like I said, it imputes gestational age for all non-live birth outcomes. And because we are reliant on data to mature so we can find these outcomes, and we're waiting for linked birth certificate data, there are some real data lags that are introduced using this algorithm that make it challenging for us to do more real-time surveillance of vaccine safety. Next slide, please. So with that in mind, we undertook some enhancements to our algorithms, and we updated the pregnancy episode algorithm so it could be run on a weekly basis. Previously, we had just been running it annually. And we also incorporated some additional sources of gestational age data. And we developed a second algorithm, which we call the dynamic pregnancy algorithm, which will allow us to identify ongoing pregnancies. Next slide, please. So just thinking about what we did to enhance our estimation of gestational age. So previously, we had only used box 1 on this slide, which is the gestational age from linked birth certificates, or box 5, which was just to impute and gestational age for the episode using a published average. What we've done now is each participating site in the VSD builds a weekly file that contains the estimated date of delivery, the EDD, or the last menstrual period, the LMP. These files are generated weekly, and so we are using them now to better estimate gestational age. Also, with the conversion from ICD-9 to ICD-10 coding that happened in 2015, there's more specific information about gestational age that are built into some of the ICD-10 codes. So we wanted to take advantage of that additional information with those codes. So now we use a hierarchy, and the algorithm comes in and says, is there a gestational age available from birth certificate data? If so, we'll take that. Then we go on to look and see if there's an EDD available. Then we use the gestational age specific ICD-10 codes. Then we use an LMP if available. And if none of those things are available, then we go ahead and look for or impute that data with the published average. So incorporating all of this additional gestational age data has really helped us improve the estimation of gestational age with the algorithm. And it also lets us better characterize pregnancies for which there is no outcome. So we're looking at pregnancies that are kind of ongoing and looking at them more in real time with this new gestational age data. Next slide, please. So the enhanced pregnancy algorithm and the DPA, we have some successes with those. Again, we've reduced our reliance on imputed dates compared to our original algorithm. We've also done some validation of these enhanced algorithms. And by validation, I mean we go out into the medical record and actually manually review that to see how well the algorithm agrees with what's in the medical record. So for live births, we have very good agreement between the algorithm on outcome type, it's 100%, and date, and we have about 97% agreement with gestational age compared to manual medical record review. And when we group pregnancy losses together, so these are including spontaneous abortions, induced abortions, and stillbirths, we find that there's 98% agreement on the outcome date and about 75% agreement on the gestational age. And one really nice thing about the DPA, this dynamic pregnancy algorithm, is when you look at episodes that will subsequently end in live birth, we can identify about 80 to 90% of those about 6 months prior to the birth. So this is really speeding up our ability to conduct maternal vaccination safety studies because we don't have to wait for those pregnancy episodes to result in an outcome before we can find them with the DPA. Next slide, please. But there are still some challenges with our algorithm. The algorithm really has some difficulty looking at pregnancy losses that occur around 19 to 20 weeks gestational age. It's very difficult for the algorithm to distinguish spontaneous abortion from stillbirth in that gestational age window. It's also difficult sometimes for clinicians to make a distinction there as well. So that is one thing to keep in mind when we're using these algorithms. We still do a lot of manual record review to collect really precise information about diagnoses and exposures, especially when we're doing studies about non-live birth outcomes. And also the algorithm does not capture pregnancies or prenatal care that occur outside of the delivery system or occur at home. And we also aren't able to capture very early pregnancy losses. Since most people present for prenatal care around 8 to 12 weeks gestation, we just can't capture those that happen earlier. Next slide, please. So we have been using the enhanced pregnancy episode algorithm to support some recent VSD studies of maternal COVID vaccination, including looking at outcomes of spontaneous abortion and stillbirth. We've also used our dynamic pregnancy algorithm to select samples of pregnant individuals so we can conduct phone surveys with them about influenza and COVID vaccination uptake in the VSD. And we've also been using these algorithms to describe COVID and influenza vaccination coverage in pregnant women in the VSD, and we are hoping to launch a report describing monkeypox vaccination uptake in pregnant individuals very soon, hopefully in the next couple of weeks. Next slide, please. So I'll just end with a thank you slide to all of the VSD contributors that have helped build and evaluate these algorithms. Thank you.
Thank you, Dr. Nalway. Are there any questions or comments from members of the committee, either in the room or online? John Dunn, go ahead.
Hi, those were terrific talks. I wanted to thank you all for that information. It's actually very exciting to me to see because vaccine safety and the extent to which we evaluate it well has always been a very difficult thing for me as a provider and me working in the vaccine space to convey to others. I wanted to just get some of your opinions on this, in particular, Dr. Chen. As I'm very excited about the idea of harmonizing what's looked at for safety for different studies, and of making sure that that these things are done uniformly, because I think it'll make us better able to assess what really is happening from study to study. I did wonder, transparency, where vaccine confidence and vaccine hesitancy are concerned, transparency about this and about what we find with vaccines is crucial. And as we do more of this and get better and better at looking at safety, there's going to be a subset of people in the world who say, well, what the heck were you doing before? Was everything in the past? Is our old information on safety not as good as it might be? And I just wondered about your thoughts about how to communicate what's being done here to the general public effectively without simultaneously undermining their confidence in the safety work that we've done in the past. And this is really a question for anybody to weigh in on.
No, I think that's a fair question. I think the main thing is that over time, in any domain, human civilization is hoping to do better than we did before. And obviously, anything that is heterogeneous is just simply difficult for human beings to handle, because at the end of the day, as I mentioned, safety cannot be measured directly by itself. You really have to look at multiple different things, and it takes energy and effort to do that. And so the now that we have more digital capability, now that we have more alliances across, hopefully within the government, across different countries, etc., then hopefully we can do better than we did before. That's not saying that people didn't try hard previously. It's just that, with each generation of new capabilities, we can do better than we did before.
Thanks very much.
And our final question is going to be from Jeff Dushin online. Jeff, go ahead.
Good morning. I'd like to second the thank you that Dr. Dunn expressed for this important work to all of you. My question is, and again to anyone, do you see the work being done in the context of CDC's public health data modernization initiative advancing our ability to monitor and understand vaccine safety? And if not, do you have suggestions for what type of enhancements we need in our public health surveillance and data systems in order to do that? Thank you.
So, Jeff, I guess we probably need to get up to speed a little bit in terms of what the content of that initiative consists of. But just assuming kind of historically, I guess I read the New York Times article recently in terms of the challenges at kind of the local and state and county health level of how the COVID-19 diagnostic data, how difficult it was to try to collate all that. And so I'm presuming that initiative is attempting to solve those kind of issues. And so very much, I think, at the end of the day, we're talking about whatever we could do to improve our knowledge, not only in terms of the diagnosis of a particular outcome, but the associated data, be it in terms of gender, be it in terms of age groups, be it in terms of ethnic groups, be it in terms of other risk factors. In the era of electronic medical records, if we could somehow make all that more accessible in a way that preserves the necessary privacy and yet allow the essential information to be gathered by public health, then I think we're heading that direction. That said, I think obviously the electronic medical records, people have been trying to work on that in the private sector for decades, and now I think the EPIC and others are finally getting there. And so similarly in the public health domain, I think we're probably in the beginning of trying to do the right thing. But we I think in the vaccine safety domain are eager to work with the CDC and others in your initiatives.
It's really helpful. Thank you.
I want to thank the members of this panel and As I switch roles here, our next panel is COVID-19 Vaccine Safety Review. In this panel, speakers will provide a review of data on COVID-19 vaccine safety. I'm going to be leading off the panel and talking about the activities of our Vaccine Safety Technical Subgroup. I'll be followed by Dr. Erin Medici from Boston Children's Hospital and Harvard, followed by Dr. Ann Hawes from CDC. So just to overview our activities for the Vaccine Safety Technical Subgroup, we have reported out to NVAC a number of times over the course of the pandemic. And our objectives throughout our activities have been to review and evaluate and interpret post-authorization and approval COVID-19 vaccine safety data, and to serve as kind of a central hub for technical subject matter expertise, and to advise on analyses and presentation of the data, as well as updating this committee and the CDC ACIP. We've continued to monitor COVID-19 vaccine safety data from a number of passive and active surveillance systems. You all have seen this slide before, and I think it's important that we recognize the number of different contributions, both within our country as well as international presenters, that have helped support our activities over the course of this last 2 years. Since from December 21, 2020 through September 19th, our committee has had 65 independent meetings to review this vaccine safety data, 16 joint meetings with the COVID-19 vaccine safety or vaccines work group, and there have been 19 ACIP meeting presentations with reports. So it's not been a passive or quiet activity. And since our last meeting in June, we've provided input to the ACIP actions. These are the ACIP topics regarding COVID-19 vaccines that have been addressed from June to September: use of Moderna and the Pfizer vaccine for younger children, use of Moderna vaccine in children and adolescents 6 to 17, use of Novavax vaccine in adults, and then use of the new Moderna and Pfizer bivalent boosters. And so our presentations have been in context of those actions. And so the three VAST assessments over that period of time, in June 23rd, in context of the Moderna vaccine for children 6 to 17, July 19th, in context of the Novavax authorization, and September 1st in conjunction with the boosters. I think it's important, again, to recognize the number of different systems here within our government and with collaborators that have provided input to our discussions. So to start with, the VAST assessment regarding monitoring data for consideration of the Moderna and Pfizer vaccines in children. The VAST reviewed data from the U.S. safety monitoring systems for Pfizer vaccine in children ages 5 to 17 and looked at comparative data on safety monitoring for Moderna and Pfizer in older age groups where that comparison was possible. We looked at data from VSafe, looking at injection site and systemic reactions. VSafe had about 50,000 participants ages 5 to 11 at the time we reviewed this information, and the reactions reported were generally mild to moderate. Most reported the day after vaccinations, and most frequently recorded after dose 2 than after dose 1. And patterns are generally similar to what were reported in the trials. This is more of a graphic presentation from a publication that was in the Lancet. We also looked at the VAERS enhanced follow-up myocarditis study, looking at those vaccinated at age 5 to 17. Over 55 or almost 55 million Pfizer doses administered to this age group. There were 635 myocarditis case reports that met the CDC case definition. And then the CDC Vaccine Safety Office group did enhanced follow-up of these myocarditis cases. In VSD, in 5 to 11-year-olds, data of almost 900,000 children aged 5 to 11. 41% completed the Pfizer series, and there were no statistical signals in the 21-day interval following vaccination. Looking again at VSD, myocarditis, pericarditis data in the 7 days after vaccination in 18 to 39-year-olds. Both vaccines were associated with an increased risk of myocarditis, pericarditis in that 7-day interval, particularly after the second dose. And there were no noticeable differences in the level of care or the clinical status between cases after one or the other vaccine. And most cases were hospitalized and had very short stays. And head-to-head comparison in these showed that the risk of myocarditis and pericarditis may be a bit higher in the Moderna than Pfizer recipients. The BEST system, a system that our FDA colleagues have used, 5.4 million Pfizer doses in children 5 to 17. There were no statistical signals in age 5 to 11. In those 12 to 15 and 16, 17, there were some signals for myocarditis and pericarditis. Further information about the BEST system basically just elucidates a bit more detail. This will be in the slides available to you later. So to summarize all of these inputs for our first presentation, I basically, in this table that was put together by Lori Markowitz and Kip Talbot, basically summarizes all of these systems in our presentation for those age 5 to 17 and then 6 to 17. But our assessment was that the risk of myocarditis and pericarditis after both messenger RNA COVID-19 vaccines in almost all cases is mild and resolves. The risk is observed in adolescents and adults, the potential risk under assessment in children under age 12, and that we needed to continue to monitor. Monitoring data are available from persons 18 and older who received the Moderna vaccine only. It was notable that at the time of this discussion, the EUA had authorized the 100 microgram Moderna dose for those aged 12 to 17 and a 50 microgram dose for those aged 6 to 11. And at the time of this discussion, it was unclear if that lower dose translated into a lower risk of myocarditis and pericarditis. Our second assessment on updates of vaccine-associated myocarditis was presented at the July 19th ACIP meeting in context of a presentation by Tom Shimabukuro. Began with an overview of the slightly different characteristics between the vaccine-associated cases of myocarditis and pericarditis as opposed to what we think of in pediatrics as typical viral myocarditis. Tends to be less severe, tends to be the people with essentially full clinical recovery. Looking at verified U.S. reports to VAERS of myocarditis after vaccination in those 18 and older, following primary series and first booster, there were about 1,320 reports verified using the CDC case definition with a median age of 28. Again, this is those age 18 and older. And most cases did resolve. The CDC Enhanced Surveillance Project, which I'll note, there's a publication that came out yesterday in Lancet Pediatric and Adolescent Medicine that details a lot of this information. But the ongoing surveillance and follow-up of these cases was to help identify their outcomes. And the key findings were at least 90 days after the myocarditis diagnosis, most patients who were reached reported no impact on their quality of life. Most did not report missing school or work. Most, and that's over 81% of healthcare providers who completed surveys, indicated the patient was fully recovered or probably fully recovered by the time that they were contacted. And there didn't appear to be a single test that was indicative of recovery and recommended additional follow-up. This looks at the primary series verified myocarditis and pericarditis reported to VAERS. The cases of verified myocarditis and pericarditis after the first booster dose, again, small numbers reported, very few that ended up admitted to the ICU. And to summarize, the current evidence supports a causal association between the messenger RNA COVID-19 vaccines and myocarditis and pericarditis. Myocarditis is a rare event following COVID-19 vaccination. CDC had verified a little over 1,300 myocarditis case reports in those 18 and older after almost 500 million doses of COVID-19 vaccine, primary and booster doses. The cases following the mRNA COVID-19 vaccines cluster within the first week after vaccination. The risk appeared greatest in adolescents and young adults, higher after dose 2 than dose 1, and that there were some occurrences after boosters. And the risk appears to decrease with age, and male to female predominance attenuates again with age. And then the final presentation in the context of Dr. Shimabukuro's presentation on September 1 looked at primary series in younger children and boosters in older children and adults. Looks at U.S. reports to VAERS among children with the primary series age 6 months to 4 years for Pfizer and 6 months to 5 years for Moderna. Total of over 1.5 million doses, with 98% of the reports being non-serious and 19 total serious reports. VSafe enrollment after almost 1.5 million doses was fairly small. VSD, again, had a small set of data, about 50,000 Pfizer and 52,000 Moderna doses administered, with no statistical signals detected at that time. And to summarize, these initial safety findings for both messenger RNA vaccines are consistent with those observed in the trials. Systemic and local reactions are commonly reported after vaccination. Vaccination errors are also being reported to VAERS, and that was a substantial portion of the VAERS reports. There were no unexpected safety findings and no evidence of increased risk for myocarditis in children aged 6 months to 5 years, which I think was helpful to all of us. Looking at reports to VAERS following the first and second mRNA COVID-19 boosters, the first row is those age 5 to 11 with first boosters. Again, non-serious reports, over 99% of reports. The second row being first boosters and those over age 12, and the final row being those with second boosters over age 50. And again, the vast majority of these reports being non-serious. This shows the reporting rates for verified myocarditis in those who had messenger RNA COVID-19 vaccinations in the first 7 days, noting that the reporting rates is highest in those 16 to 17, followed by those 12 to 15, and those 18 to 24, again in males. And the reporting rates after the first booster being elevated, but lower than that after the second dose. And there are some increased reporting rates, but significantly lower in the female population. The VSD results in children aged 5 to 11 for the first COVID booster. There were no statistical signals. And this shows the VSD incidence rates for verified myocarditis and pericarditis after Pfizer vaccination. You'll note the reporting rate, the number of reports is very small, and so these calculated rates are imprecise. You see wide confidence intervals. Similar data for Moderna. If you'll note, the reports are only for the indicated ages. We didn't have data before or under age 18. So to summarize, the messenger RNA COVID-19 vaccine safety and booster doses in people 5 years and older. Safety findings are generally consistent with those observed for the primary series. Evidence again suggests an increased risk for myocarditis following the first booster dose. It's a rare event following our messenger RNA vaccines. The CDC has verified 131 myocarditis cases reported to VAERS in people aged 5 and older, following 123 plus million messenger RNA COVID-19 booster vaccinations. The risk is primarily in adolescent and young adult males, with no statistical signal for myocarditis to date in children aged 5 to 11 following the first booster. In the VAERS data, the reporting rates for myocarditis are lower following the first booster than after dose 2. In the VSD analysis, myocarditis, pericarditis incidence following the first booster and dose 2 in the primary series are similar, although again, the case counts are small and the confidence intervals around these point estimates are very wide. And then the final element to present to you on COVID-19 vaccine safety regarding pregnancy and reproductive health outcomes. Monitoring systems that have participated in this were VSafe, the VSafe Pregnancy Registry, VSD, VAERS, and the CISA project. And as you see, we've looked at a large number of outcomes and topics, including miscarriage, stillbirth, preterm birth, menstrual irregularities, SARS-CoV infection, pregnancy outcomes, and infant outcomes. And to date, of those outcome studies, there have been no concerning findings for pregnancy or reproductive health outcomes following COVID-19 vaccinations. and the data on our COVID-19 vaccine safety during pregnancy and reproductive health outcomes will be presented in more detail at future ACIP meetings. And with that, I will end my presentation. Again, much more detail than what I've presented here today in the slides, but I didn't want to spend all day up here in front of you. So our next presenter is Dr. Erin Medici from Boston Children's Hospital in Harvard. Dr. Medici, your slides are up.
Thank you very much, and good morning.
Morning, you have the floor.
Thank you, sir. So thank you, everyone, for the opportunity to share our findings with you and answer any questions you may have. I will be describing our study on the comparative safety of COVID-19 mRNA vaccines, specifically comparing the BNT162b2 and mRNA 1273 vaccines. This work is a scientific collaboration between the Veterans Affairs Hospital researchers and the causal lab at Harvard School of Public Health, which is a close partnership. Next slide. To start, I wanted to describe what we knew at the onset and of our plan to study these comparing these two vaccines. So we knew that the mRNA-based COVID vaccines in broad strokes are safe based on the initial effectiveness data from randomized trials. And I display here these two studies published in 2020 in which 21,000 and 15,000 individuals received each vaccine respectively. Overall, a very low rate, 0.6% of serious adverse events with variable follow-up. Greater than 2 months for the former study by Pollack et al., and a median of 28 days by the second study by Baden et al. However, we're unable to make any comparisons between these two different treatments because the populations may be different between these studies. If you wouldn't mind advancing the slide. So the take-home message was these vaccines appear to be safe, but we don't have any head-to-head comparison, which could be very important knowledge to have if population-based vaccinations were undertaken as they were. Next slide. Now, surely these are small differences in safety, but on the population level, as I said, these really do matter. Unfortunately, they're impractical to study with the RCTs that are so helpful and critical for studies of effectiveness. Just as we had just heard about during the previous presentation, there are fortunately many excellent sources of observational data that can complement these early trials. While we can't have a trial for everything due to a number of different constraints, both in terms of time, funding, and ethical concerns at different times, we do have observational data analyses which can complement these trials and fill in the gaps. Furthermore, these observational studies are often larger studies and generally in more diverse populations compared with the initial trials. We can study a broader array of safety outcomes and can have longer duration of follow-up. The estimates will be more precise because of the larger populations, and we can benchmark these against the trial data to make sure that they are in the right range. The goal with our studies was ultimately to inform population vaccination by these mRNA vaccines in considerations in the future. Next slide. To learn about anything, including vaccine safety from observational data, we need to be very careful. Randomized trials are certainly the gold standard. And what we generally suggest is that we need to pose first a causal question and imagine a hypothetical intervention that we would make and then imagine how we would study that in a randomized trial. And in doing so, we specify a protocol of what our target trial is, our target randomized trial that we would want to conduct. And then in step 2, we answer this causal question by conducting the target trial, specifically emulating it with our observational data. Next slide, please. The key elements of any target trial, randomized trial, would be eligibility criteria, treatment strategies, treatment assignment, when the beginning of follow-up or time 0 occurs, and what duration of follow-up will be studied, the outcomes of interest, causal contrast, meaning intention to treat or for protocol effects, and then the data analysis plan. And next slide. We specify these elements of the protocol, and then we emulate them as closely as possible using observational data. Next slide, please. As I mentioned, we imagine a hypothetical randomized trial that we would like to conduct. In this case, one of vaccine safety. By doing so, we would learn what works or what harms, and then we make an attempt to emulate this trial. Next slide. In our case, our target trial would study the risk of adverse events with these 2 mRNA-based COVID-19 vaccines. Our eligibility criteria included adult veterans who had no previous history of COVID-19 vaccination and no history of prior infection with SARS-CoV-2. Additionally, these individuals had no history of the adverse event of interest, and as I mentioned and will describe in further slides, we studied a broad array of adverse events. And these were individuals who were actively using the VA healthcare system as described in the footnote, such that they would present presumably to medical attention at the VA healthcare system, and we would observe these outcomes. The 2 treatment strategies, the 2 arms of this hypothetical randomized trial, were to receive either 1 dose of BNT162b2 vaccine at baseline with a second dose 28 later, or 1 dose of the mRNA 1273 vaccine at baseline with a second dose 28 days later. In our hypothetical trial, we would randomize participants to a strategy at baseline. We may want to block randomize within strata, and the strata of interest would be calendar date, age, sex, race, urbanicity of residence, and geographic location. This would be a study in which participants were aware of the assigned treatment strategy, in that it would be non-blind. Next slide, please. Finally, for follow-up, this would start on the day of vaccination and end at the time of the outcome of interest, SARS-CoV-2 infection diagnosis, 38 weeks, which was our selected end of follow-up, or the end of the study period. We assessed the following adverse events individually: neurologic events, which included things like Bell's palsy, vertigo, and syncope; hematologic events, which included lab abnormalities of complete blood count; hemorrhagic stroke, ischemic stroke, myocardial infarction; other thromboembolic events, myocarditis or pericarditis; arrhythmias; kidney injury; appendicitis; autoimmune events; herpes infection; arthritis or arthropathy; and pneumonia. The causal contrast was a per protocol analysis, and our data analysis plan included estimating a non-naive per protocol effect and conducting subgroup analyses by baseline age and race. Next slide, please. Now, that's the hypothetical randomized trial that we would want to conduct if we could. Certainly, we cannot do that study at this point. So we emulate this target trial, and we proceeded in doing so using very rich clinical data from the Department of Veterans Affairs electronic healthcare database warehouses. I identified some salient points here, including that vaccination was identified in both the immunization domain and in the procedures domain, or in procedures recorded in the outpatient and inpatient domains. And then SARS-CoV-2 infections were identified using the VA COVID-19 National Surveillance Tool, which integrates PCR tests and natural language processing, or NLP, of clinical notes. And so this captures SARS-CoV-2 infections diagnosed inside and outside of the VA healthcare system. The next slide, please. I displayed here a flow diagram of the entire population of eligible veterans, approximately 6 million. Those who had not been vaccinated after September 21st were approximately 3.5 million. Other exclusion criteria led to approximately 1 million individuals evaluated for inclusion in the study. Some of those received a different vaccine, and so were not included in the analysis. And then ultimately, next slide, please. We have about 370,000 and 400,000 who received the vaccines of interest. Of note, we excluded participants who were vaccinated at VA stations that did not also offer the alternative vaccine, the other vaccine. Next slide, please. And so after matching on the covariates of interest, we had, next slide, please, 200,836 included in each match group. Next slide, please. So this covariates included in the matching were calendar date within 5-day intervals, age within 5-year intervals, sex, race, urbanicity of residence, and geographic location. And these measured covariates were found to be well balanced within the two groups. Next slide, please. I now present a series of our results, and I leave these in a figure form. We certainly have the numerical values available in our paper as well. But starting with neurologic events and hematologic events, to note, over 266 days, which was the end of follow-up, the risk of either of these events was on the order of approximately 3%, and very similar between the two vaccine groups. So overall, low 38-week risk of adverse events. Next slide, please. Similarly, for hemorrhagic and ischemic stroke, these were on the order of 0.5% and 0.8% at the end of follow-up, and generally similar between groups for hemorrhagic stroke, slightly higher for BNT162b2 with ischemic stroke, but again, very low overall risk. And next slide, please. For myocardial infarction and other thrombotic events, these were slightly higher with BNT162b2 at the end of follow-up, however, extremely low, again, risk on the order of 0.6%. Next slide, please. Myocarditis and pericarditis, the estimates were imprecise given the very low number of events, as you can see, but less than 0.05%. With arrhythmia, about 2.5%, similar between both groups. Next slide, please. Next, as you can see, renal injury was slightly higher with BNT162b2 on the order of around 1%, and the risk of appendicitis, which had been studied in prior papers, was extremely low, around 0.05%, and very similar between groups. Next slide. Autoimmune events and risk of herpes virus reactivation were similar between groups. Next slide, please. And risk of arthritis was also similar between groups and approximately 0.5% at the end of follow-up. Next slide, please. So a summary of all of these figures was that we did find that recipients of the mRNA 1273 vaccine had a lower risk of stroke, myocardial infarction, thromboembolism, and kidney injury at the end of follow-up, as displayed here. However, perhaps the most important takeaway is that the overall risk of events is very low at the end of follow-up. Next slide, please. These differences were, risk differences were less than 0.2%. Next slide. In conclusion, there were low absolute risk of all studied adverse events regardless of vaccine received. Next slide, please. We were able to study a longer period of follow-up in more diverse population compared with the initial randomized trials. Next slide, please. And there is evidence for lower 38-week risk of ischemic stroke, myocardial infarction, other thromboembolic events, and kidney injury for the mRNA 1273 as opposed to the BNT162b2 vaccine. It's possible that some of this effect could be due to greater effectiveness of the mRNA 1273 vaccine in preventing SARS-CoV-2 infections, as these events are also sequelae of COVID infection. However, we did try to account for this in the analysis by censoring individuals at the time of SARS-CoV-2 infection diagnosis. Next slide, please. I'd like to thank all of our collaborators at the VA and within Causal Lab and the VA Causal collaboration. Next slide, please. Thank you very much for your time, and I'll be happy to take any questions.
Thank you, Dr. Medici. Our next presenter is Dr. Ann Hawes. Dr. Hawes, your slides are up.
Thank you. I don't think these are my slides.
Give us just one second, Dr. Krause.
Okay, thanks. So today I'll present findings from VSafe on reactogenicity of simultaneous COVID-19 mRNA booster and influenza vaccination. Next slide. So I'll just start with a little bit of background first. Next slide. So the CDC recommends everyone ages 6 months and older receive a COVID-19 vaccine. COVID-19 vaccines may be administered without regard to timing of other vaccines, including on the same day, and I'll refer to this as simultaneous vaccination. The one exception is orthopox vaccination. More information regarding COVID-19 and orthopox virus vaccination is available in the interim clinical considerations. So utilizing simultaneous vaccination increases the likelihood that people will be kept up to date on all their recommended vaccines. Next slide. COVID-19 vaccines are being administered under the most intensive vaccine safety monitoring effort in U.S. history. CDC monitors the safety of these vaccines using 4 complementary systems: VSafe, VAERS, VSD, and CISA. There are also additional systems in place managed by government partners. Next slide. Today, I'm going to focus on data from VSafe. VSafe is a voluntary smartphone-based active safety surveillance system that allows anyone to enroll after any dose of COVID-19 vaccine. Next slide. When a participant enters a COVID-19 vaccine dose in VSafe, they can indicate if any other vaccines were administered at the same time. VSafe then uses text messages to provide links to web surveys. The surveys are sent daily during the week following each dose of vaccine, and they include questions about local injection site and systemic reactions, as well as health impacts. Additional health surveys are also sent weekly through 6 weeks after vaccination, and then at 3, 6, and 12 months following vaccination. Next slide. So now I'm going to present some findings from our study on simultaneous COVID-19 booster and influenza vaccination. Next slide. So this study was published in JAMA Open Network and used data from last year's influenza season. For this study, we compared self-reported injection site and systemic reactions and health impacts in the week following simultaneous influenza and mRNA booster vaccination to mRNA booster vaccination alone. In VSafe at the time of this study, influenza vaccine was the most common simultaneously administered vaccine, and most simultaneous vaccinations occurred with booster doses, so that informed the study design. We excluded persons who reported multiple simultaneous vaccines, booster doses that were administered prior to authorization, and doses administered to age groups for which the vaccines were not yet authorized. There were 92,023 persons who received simultaneous influenza and mRNA booster, and 889,076 persons who received mRNA booster alone. Next slide. This figure shows local reactions reported at least once during days 0 through 7 after mRNA booster vaccination. Pfizer-BioNTech vaccination alone is shown in light blue, Pfizer-BioNTech and influenza in dark blue, Moderna alone in light orange, and Moderna and influenza in dark orange. Pain, swelling, redness, and itching were similarly reported or slightly more frequently reported when vaccines were simultaneously administered. Next slide. This figure shows the top 4 systemic reactions reported at least once during days 0 through 7 after mRNA booster vaccination. Fatigue, myalgia, headache, and fever were similarly reported or slightly more frequently reported when vaccines were simultaneously administered. Next slide. This figure shows health impacts reported at least once during days 0 through 7 after mRNA booster vaccination. Inability to perform normally daily activities, inability to work or attend school, and receipt of medical care were similarly reported or slightly more frequently reported when vaccines were simultaneously administered. Next slide. This figure shows the top 4 solicited reactions reported at least once during days 0 through 7 after mRNA booster vaccination by self-reported severity. Mild reactions are shown in blue, moderate in orange, and severe in gray. Abbreviations for the different vaccine combinations are shown along the x-axis. Most reactions were mild to moderate, and there was no evidence suggesting a difference in severity. Next slide. So these figures show odds ratios for any injection site or systemic reaction and health impact following mRNA booster and seasonal influenza vaccine compared with mRNA booster alone. The odds ratios were adjusted for age, sex, and week of vaccination. On the x-axis of each figure, to the left of the one are the differences in which more reactogenicity was observed with the COVID-19 vaccines alone. And to the right are the differences in which more reactogenicity was observed with COVID-19 and influenza vaccine simultaneously administered. So participants who simultaneously received influenza vaccine and either mRNA COVID-19 booster were slightly more likely to report a systemic reaction or injection site reaction. Participants who received simultaneous administration of Pfizer-BioNTech and the influenza vaccine were not more likely to report any health impact, while participants who received simultaneous administration of Moderna and influenza vaccine were slightly more likely to report any health impact. Reporting differed by specific health impact. Next slide. So to summarize, these initial findings from VSafe indicate that injection site and systemic reactions are more frequently reported following simultaneous administered mRNA booster vaccine and influenza vaccine than mRNA booster alone. However, this increase in reporting is very small, and there was no evidence to suggest a difference in severity. So CDC will continue to monitor the safety of these COVID-19 vaccine, including simultaneous administration of vaccination. And next slide. And that concludes my presentation.
Thank you, Dr. Hawes. We appreciate your presentation. Are there any questions or comments from members of the committee? Tim Cook.
Yeah, that was a great session. Thanks so much. I had a question for Dr. Medenci, and it had to do with wanting to see the non-vaccinated, the placebo group in that comparison study you did. That must be very hard to do. I just don't know if you thought about doing it, those who were not vaccinated, and seeing that on the chart with the other two groups.
Thanks very much for your question. That's a very good point. It's something we actually discussed at length, because that question has come up quite a bit, as you might imagine. The issue in doing so in terms of study design is that at this point in the pandemic, when these vaccines were being given, there wasn't a fair and safe hypothetical randomized trial that we would conduct in which we would choose to not vaccinate some individuals. And so with that in mind, emulating such a trial would be very challenging, and we thought too challenging for the reason of confounding by either indication or patient choice. And so we felt that we would not be able to even approximately emulate randomization with our measured covariates.
Any other questions or comments? And are there any in the chat? All right, well, thank you all very much for the panel, and we'll now go to break. I have now 10:48. We're going to break until 11 a.m. Eastern Time, and then we'll come back for our next presentation, which will be monkeypox vaccine safety review. Thank you for attending our September NVAC meeting.
Produced by the U.S. Department of Health and Human Services.